আজকে ক্লাস রয়েছে ইমিউনোমডুলেটরস উপরে, ঠিক আছে। হোয়াট ডু উই মিন বাই ইমিউনিটি? ইমিউনিটি মানে কি, জোরে বলো। Immunity is something by which a human being differentiate between the self and non-self and fight against the non-self. The non-self protein can be an infection or a cancer cell. The word immunomodulators basically signifies modulating the immune system by using of drugs that can be either by strengthening the immune system or suppressing the immune system. Now, immunology is a branch of science that basically deals with the physiology of self and non-self discrimination. The immune system must not react with the self component. What happens if the immune system reacts with the self component? That will result in autoimmune disease. Can you name some examples of autoimmune disease? Anyone? Like rheumatoid arthritis, already done. So the non-self component could be an infectious organism like bacteria, virus and parasites. A transplanted organ, it can be renal transplant, liver transplant, or an endogenous cell that can be mistaken as a foreign body. So that results in autoimmune disease. Now, what are the types of immunity we have? As per our knowledge from the physiology, it can be innate immunity or adaptive immunity. So, immunity can be broadly classified into innate immunity and adaptive immunity. What do we mean by innate immunity? Is basically the immunity that is present since birth. So, it is rapid, immediate, non-specific, no memory is required for this response. Neutrophils, macrophages, natural killer cells, they exhibit the innate immunity resulting in initial defense and inflammation. What do we mean by adaptive immunity? It develops over time, it is acquired. Now, it is slower to develop over time, highly specific, long-lasting memory is seen. Here the T and B lymphocytes are involved and they result in specific pathogen elimination and the long-term immunity. Now, adaptive immunity can again be classified into humoral and cell-mediated immunity. In the humoral immunity, basically the extracellular microbes are involved. Here the immunity is shown by B lymphocytes, which result in the production of antibodies. We know 5 types of antibodies are there. Now, coming to the cell-mediated immunity, they result in the phagocytosis of the microbe in the macrophage or intracellular microbe replicating within the infected cells are killed by the cell-mediated immunity. Here, helper T cells or the cytotoxic T cells are involved. And now, these are the schematic diagram of the immune system, humoral and cell-mediated immunity. Here the basically antigen presenting cells, they are presenting antigen to the CD helper cell, and then CD4 helper T cells, after activation it is result in the production of interleukin 2 and the other cytokines that results in the activation of the cytotoxic T cells. Now, coming to the immunomodulators. Now, all drugs which modify immune responses are generally categorized as immunomodulators. It can be immunosuppressants, it can be immunostimulants. Now, there is also an upcoming generation of immunosuppressant called tolerogens. Now, these immunosuppressant drugs, they either inhibit the cellular or the humoral immunity or both of them. They have their major use in number 1 organ transplantation, number 2 autoimmune disease, and number 3 in basically graft rejection. Now, these are the immunosuppressant drugs available. Number 1, very important, calcineurin inhibitors. These are specific T cell inhibitors. They include basically cyclosporine and Tacrolimus. Number 2, mTOR inhibitor, that includes sirolimus, everolimus, anti-proliferative drugs or the cytotoxic drugs that include azathioprine, methotrexate, cyclophosphamide, chlorambucil, mycophenolate, mofetil. Then glucocorticoids, prednisolone and others. And lastly, and the recent addition, biological agents that include TNF alpha inhibitors, etanercept, infliximab, adalimumab. Then comes interleukin 1 receptor antagonist, anakinra, IL-2 receptor antagonist, daclizumab and basiliximab. Anti-CD3 antibodies that include muromonab CD3, and polyclonal antibodies, they include anti-thymocyte globulin and anti-rhodioglobulin. So basically, is a schematic diagram showing how the different immunosuppressants are acting. Now, this cyclosporine, basically they bind to the immunophilin, protein that inhibit calcineurin. Calcineurin is activated after activation of the T helper cell that result in the activation of NFAT. This NFAT protein, natural killer fat protein, they basically translocate to the nucleus and results in the transcription of various cytokine gene. Now, because of the inhibition of calcineurin, subsequent steps of T cell activation is inhibited, and thus they are showing immunosuppression effect. Tacrolimus, basically the mechanism of action is same as that of cyclosporine, but instead of binding to the cyclophilin, they are binding FK binding protein, and thus they are inhibiting calcineurin. Sirolimus, basically they are binding to the FK binding protein like that of the tacrolimus, but the effect is downstream steps. Basically, this after binding to the FK binding protein, they inhibit the mTOR, mammalian target of rapamycin, and thus they are inhibiting the subsequent steps of the activation of T helper cell. Now, coming to the cyclosporine, basically is a cyclic polypeptide with 11 amino acids. The source is from a fungus introduced in 1977 as a highly specific immunosuppressant, which has markedly increased the success of organ transplantations. Now, it selectively inhibits the T lymphocytes, interleukin 2 and other cytokine production. Lymphocytes are arrested in G0 and G1 phase. Now, they are basically, they inhibit the cell-mediated immunity. Humoral immunity is minimally disturbed. Now, cyclosporine enters the target cells. They bind to the cyclophilin. As said earlier, is an immunophilin protein, and thus they inactivate the calcineurin, and thus the response of the helper T cell to the antigenic stimulation fails. Cyclosporine also enhances the production of transforming growth factor beta, TGF beta, and which is an inhibitor of IL-2, and thus they are also is also one of the mechanism of action. Cyclosporine is most active when the drug is administered before the antigen exposure. They are useful in autoimmune disease as well. Now, they selectively suppress the cell-mediated immunity, as said earlier, because their action is on the T cells, not the B cells. They prevent graft rejection, humoral immunity remains intact, and the most serious complication with the use of cyclosporine is nephrotoxicity. They also impair liver function. Other side effects can be sustained rise in blood pressure, precipitation of diabetes, anorexia, lethargy, hyperkalemia. So they are not used with the drugs that cause hyperkalemia, hyperuricemia, opportunistic infection, hirsutism, gum hyperplasia, tremor and seizure. এই যে gum hyperplasia আর hirsutism আর কোন ড্রাগের সাইড এফেক্টটা ছিল প্রমিনেন্ট? সিএনএস এ পড়েছি আমরা। is with phenytoin. Okay. Now, they are also used in graft rejection reaction. It is routinely used in many types of transplant like renal, hepatic, cardiac, bone marrow and other transplantations. Drug is to be started 12 hours before the transplantation and continued for as long as needed. Now, it is concentrated in WBC and RBC, metabolized in liver by CYP3A4, excreted in bile. Plasma TF is biphasic, 4 to 6 hours and 12 to 18 hours. Now, it is the second line drug in some autoimmune disease like severe rheumatoid arthritis, uveitis, bronchial asthma, inflammatory bowel disease, dermatomyositis and in psoriasis, especially to suppress the acute exacerbations. It can be used along with steroid or the methotrexate. Some good results have been obtained in patients of aplastic anemia also, where it is used in lower dose. Now, they also interact with a large number of drugs. The drugs which are nephrotoxic should not be combined with cyclosporine, as the drug itself is nephrotoxic. So, it should through the combination with aminoglycosides, vancomycin, amphotericin B and NSAIDs should be avoided. The drug is metabolized by CYP3A4. So, enzyme inducers like phenytoin, phenobarbital, rifampin, they lower its blood level. Again, CYP3A4 inhibitors like erythromycin, ketoconazole and related drugs, they inhibit its metabolism and toxicity chance is increased. Potassium supplements and potassium sparing diuretics can cause marked hyperkalemia. Coming to the next drug of the same class, Tacrolimus. It is also denoted by FK506. Chemically different from cyclosporine, but the mechanism is same, 100 times more potent. Instead of binding to cyclophilin, which the cyclosporine do, it binds to FK binding protein, FKBP, and the subsequent steps are same. Administered orally as well as by IV infusion, metabolized by CYP3A4 again. Blood level monitoring is needed for dose adjustment like that of cyclosporine. They are preferred now for organ transplantation. Why? Because of higher potency and easier monitoring of blood level. They are useful in patients whose rejection is not suppressed by cyclosporine. So, in the rejection where cyclosporine is not effective, the drug can be used tacrolimus. They are particularly valuable in liver transplant. Why? Because their absorption is not dependent on bile. They are also useful in suppressing acute rejection. They are useful in fistulating Crohn's disease. A 10-week course may induce remission. Topically, it is useful in atopic dermatitis. Hypertension, hirsutism, gum hyperplasia, hyperuricemia are less marked with cyclosporine. Nephrotoxicity is less marked, but it can precipitate diabetes. Neurotoxicity can occur, alopecia, diarrhea. Nephrotoxicity is there, but chances lesser than cyclosporine. Coming to sirolimus. Sirolimus is similar in structure to the tacrolimus. It's a macrolide antibiotic initially introduced in the market with the name rapamycin. Okay, it was earlier named rapamycin. It binds to the protein FKBP, that is basically FK binding protein like that of tacrolimus. But subsequent steps are different. Sirolimus FKBP complex inhibit another kinase, mTOR, called mammalian target of rapamycin, and does not interact with calcineurin like that of the basically calcineurin inhibitors. The mTOR is an important link in the cascade of signaling pathways leading to the proliferation and differentiation of T cells activated by interleukin 2 and other cytokines. Sirolimus arrests the immune response at a later stage than cyclosporine or tacrolimus. Inhibitors and inducers of CYP3A4 significantly alter its blood level, which need to be monitored. Now, they are used for prophylaxis and therapy of graft rejection. can be used alone, but is generally combined with lower doses of cyclosporine or tacrolimus with the corticosteroids and mycophenolate mofetil. It is particularly suitable for patients developing renal toxicity with cyclosporine. It is effective in some steroid refractory cases also. It has been used in stem cell transplant. It is not recommended for liver transplantation. Now, there are certain drug-eluting stents that are used in coronary angioplasty. So, the drug used here is sirolimus, which basically reduces the incidence of coronary artery restenosis by inhibiting endothelial proliferation. Now, sirolimus is not nephrotoxic, but they inhibit the bone marrow, but they cause bone marrow suppression, particularly linked to thrombocytopenia. Rise in serum lipid can be seen. Other side effects: diarrhea, liver damage, and pneumonitis. Coming to the next class of drug, that the anti-proliferative drugs or cytotoxic immunosuppressants. They prevent the clonal expansion of the T and B lymphocytes. Now, the first drug here is azathioprine. It is a purine anti-metabolite. It has got marked anti-tumor activity and immunosuppressant activity. The selective uptake into the immune cells is seen with azathioprine. So, they have got more immunosuppressant activity, not the anti-tumor activity. Then what happens basically, it's a prodrug that is converted to 6-mercaptopurine intracellularly, which then undergoes further transformation to inhibit the de novo purine synthesis that has to be incorporated into DNA. It selectively affects differentiation and function of T cells and inhibits cytolytic lymphocytes. So, they are more cell-mediated immunity inhibitors, not the humoral immunity inhibitor. They basically the most important application is prevention of renal and other graft rejection. They are less effective than cyclosporine, generally combined with it or used in patients developing nephrotoxicity due to cyclosporine. Relatively lower dose are used in progressive rheumatoid arthritis and for maintaining remission in inflammatory bowel disease. It may be an alternative to long-term steroids in some autoimmune disease. Methotrexate is a folate antagonist. It markedly depresses cytokine production, cellular immunity, and they possess anti-inflammatory action as well. Now, it has been used as a first-line drug in many autoimmune diseases. Like in case of rheumatoid arthritis, it is the first-line drug. In severe psoriasis, pemphigus, myasthenia gravis, uveitis, and chronic active hepatitis. Low-dose methotrexate maintenance therapy is relatively well tolerated. They have got more cyclophosphamide. Basically, they have got more marked effect on the B cells compared to the T cells. So, they affect humoral immunity more. It has been particularly utilized in bone marrow transplantation, where a short course is given. In other transplant, it is employed only as a reserve drug. In rheumatoid arthritis, it is rarely used when other systemic manifestations are marked. Well, chlorambucil is relatively weak immunosuppressant, where it is sometimes utilized in autoimmune disease and transplant maintenance regimen. Coming to mycophenolate mofetil, MMF is a prodrug, and the active moiety is mycophenolic acid. Now, it selectively inhibits IMP dehydrogenase, inosine monophosphate dehydrogenase. It is an enzyme essential for de novo synthesis of guanosine nucleotides in T and lymphocyte proliferation, antibody production, and the cell-mediated immunity are inhibited. Now, it is an add-on drug to cyclosporine and glucocorticoid in transplant maintenance regimen in renal transplantation, but it should never be combined with azathioprine. Now, MMF, glucocorticoid, and sirolimus. This is a non-nephrotoxic combination that is utilized in patients with renal toxicity with cyclosporine or tacrolimus. Generally, cyclosporine is preferred but where the patient has developed renal toxicity, the cyclosporine can be changed with sirolimus. MMF is rapidly absorbed orally, quickly converted to active metabolite, mycophenolic acid, and slowly inactivated by glucuronidation with a T-half of 16 hours. Vomiting, diarrhea, leukopenia, and predisposition to CMV, cytomegalovirus infection, gastrointestinal bleed are some of the prominent side effects. Coming to the glucocorticoid, it's a potent immunosuppressant and have anti-inflammatory activity. They inhibit MSC expression and activation or proliferation of T lymphocytes. The interleukin productions, the cytokine productions are decreased with corticosteroids and also the production of additional molecules. What happens? There is a short-lived lymphopenic effect with the use of steroid, and they have got marked effect on the CMI, cell-mediated immunity. Now, they are used in various organ transplant, in the graft rejections. They are also used practically in all cases of severe autoimmune disease, especially during their exacerbation periods. Prolonged duration therapy is avoided because of long-term complications with steroid. Biological agent, these are biotechnologically produced monoclonal or polyclonal antibodies directed against the cytokines or the lymphocyte surface antigens. They are the supplementary or the reserve drug for severe and refractory cases of autoimmune disease and the graft versus host rejection. Now, among the biological agents, very important first one, TNF alpha inhibitors. Now, TNF alpha inhibitors basically, TNF alpha is secreted by activated macrophages and other immune cells. They act on the receptor TNF receptor 1 and 2 located on neutrophils, fibroblasts, endothelial cells, and the free soluble form in the serum and serous fluid. TNF alpha amplifies the immune inflammation by releasing other cytokines and enzymes like collagenase and metalloproteinase. Now, TNF alpha inhibitors are particularly useful in autoimmune disease. Examples include infliximab, which is more commonly used, etanercept, and adalimumab. Coming to the next class, Muromonab CD3 is a murine that is obtained from the mouse. It is a murine monoclonal antibody against the CD3 glycoprotein. CD3 is expressed in the T helper cell near to the T cell receptor. Now, what happens when the CD3 muromonab, it binds to the CD3 antigen? They obstruct the approach of MSC2 to the T cell receptor. Antigen recognition is interfered. As a result, T cell participation in immune response is not there. What happens? Due to the binding of muromonab CD3 to CD3 receptor, the T cell receptor is not able to function. T cell is getting rapidly depleted from the body, from the blood basically, and they either goes to the non-lymphoid organs or they are basically resolved by cytolysis and immune blocked state results. They are particularly useful for acute transplant rejection. The transplant rejection can be accelerated, can be acute, can be chronic. Accelerated is seen in first week of transplantation, acute is seen in 2 to 12 weeks of transplantation, and chronic transplantation is seen after 12 weeks. So, it is primarily used for acute transplant rejection, particularly in steroid resistant case. Acute transplant rejection, the drug of choice is corticosteroids. Now, generally only the one course is given, subsequent courses are not given. Why? Because it is a murine antibody. First course produce antibodies against the mouse protein which neutralize it. It is also included for induction therapy of organ transplantation, but is now infrequent with the advent of newer drugs, safer drugs. It also used to deplete T cells from the donor bone marrow before the transplantation. Now, as it is a murine monoclonal antibody, the use of Immunomonab CD3 causes cytokine release syndrome, resulting in fever, chills, body ache, wheezing, malaise due to the release of TNF alpha, interleukins and interferons. Now, how this can be prevented? By the use of high dose corticosteroid treatment, pre-treatment before the drug attenuates the reaction and is a part of usual protocol while administering Immunomonab CD3. Coming to the next, polyclonal antibodies that include anti-thymocyte globulin. It's a polyclonal antibody purified from the horse or the rabbit, immunized with human thymic lymphocytes. It binds to T lymphocytes and depletes them. It is used in acute allograft rejection. Allograft rejection mane? Allograft mane? Sorry? How many types of grafts are there? It can be allograft, that is obtained from the same species. It can be isograft, obtained from the same person. It can be xenograft, obtained from different species. So, it is used in acute allograft rejection, especially in steroid resistant case. It can be also used in induction regimen. Induction regimen পড়বো আমরা জানাচ্ছি। But this has the potential to produce serum sickness or anaphylaxis as it is obtained from the horse or rabbit. Coming to anti-D immune globulin. We all know we have got 4 types of blood group: A, B, O and AB. Now these are denoted by either positive or negative. So this positive or negative is determined by the presence of D antigen. Now what happens when, for example, basically blood group negative D, Rho D negative in the mother carries the Rho D positive baby. What happens during the time of delivery or during the abortion? The fetus blood comes in contact with the mother blood. The baby blood is Rho D positive and the mother blood is Rho D negative. So what happens? There can be serious hemolytic reactions. So they are used for the prevention of postpartum or post-abortion formation of antibodies in Rho D negative or DU negative women who have delivered or aborted an Rho D positive or DU positive baby or fetus. That has to be administered within 72 hours of delivery or abortion. Otherwise, such treatment prevents Rh hemolytic disease in future offspring. It has also been given at 28th week of pregnancy. Higher doses are needed for Rh negative recipients of recipient of blood. Inadvertently administered Rh positive blood. একটা Rh negative individual তাকে Rh positive blood দেওয়া হলো. That can lead to serious reactions and that can be overcome by the use of higher dose of anti-D immune globulin. Coming to immunosuppression in the organ transplantation. Now, the use of immunosuppressants is essential for successful organ transplantation. যে কোনো organ transplantation requires the use of immunosuppressant. Generally, triple drug therapy is preferred, not a single or dual. Now, in general, 3 types of regimens are used. One is induction regimen, one is maintenance regimen, and other is anti-rejection regimen. Coming to induction regimen, it starts from the perioperative period, generally 12 hours before the therapy procedure, starting just before the transplant and continues up till 2 to 12 weeks post-transplant. Now, 3 types of rejection can be seen. Accelerated rejection develops in the first week, acute rejection develops in the 2 to 12 weeks period, and chronic rejection post 12 weeks. The most common regimen in the induction regimen is the triple therapy that includes either cyclosporine or tacrolimus or sirolimus, any one, plus corticosteroid prednisolone, plus either MMF or azathioprine. Sirolimus, prednisolone and MFF combination, they avoid the risk of nephrotoxicity. Two drug and single drug regimen are also used, but that carries a higher chance of rejection. Many experts do not give cyclosporine pre-operatively and try to delay it to avoid the nephrotoxicity. If no rejection develops, the doses are gradually reduced after 2 weeks, and this phase merges with maintenance phase. Maintenance phase, they start from 2 weeks post-operatively and can be continued for very long, even lifelong. Triple drug regimen is preferred, that includes cyclosporine or tacrolimus, sirolimus, prednisolone, azathioprine or MMF, any three. Because each component is needed in lower dose, reduces toxicity and the cost. Nephrotoxicity is often the limiting factor with the use of cyclosporine or tacrolimus, and with the steroid, long-term use of steroid carries its own complications. Now, 2 drug and 1 drug regimen can be used, but they are basically linked to higher rejection episodes. In case of intolerance to the first line drug, the second line drugs can be used like cyclophosphamide, chlorambucil or daclizumab. Coming to anti-rejection regimen that are used when there is rejection of the transplant, it is given to suppress an episode of acute rejection. Generally, steroid pulse therapy is preferred. Methylprednisolone 500 mg to 1 gram once daily for 3 to 5 days. It is effective in majority of the cases. In case of no response, muromonab CD3 or anti-thymocyte globulin can be used as rescue therapy, or it can be combined with the steroid. Tacrolimus, sirolimus and mycophenolate mofetil, they are also used as rescue therapy in steroid resistant case. Cyclosporine can be helpful if it was not included in the maintenance regimen. What are the adverse effects of the immunosuppressant drugs? Very important is opportunistic infection, increased chance of bacterial, fungal and viral infection, particularly cytomegalovirus, development of lymphomas and other related malignancies after a long latency. Coming to the next group of drugs, immunostimulants. A number of disorders such as immunodeficiency state like AIDS, autoimmune disease, cancer and viral infections can be treated with immunostimulant drugs. These agents are non-specific, they affect both cellular and humoral immunity, and they are also called biological response modifiers or immunomodulators. Number 1, Bacillus calmette-guerin. We all know BCG vaccine. Now, it is an attenuated live culture of calmette-guerin strain of Bacillus Mycobacterium bovis. They stimulate both T cells and natural killer cells. They are used to treat urinary bladder cancer, and it is instilled and held for 2 hours before urination. Coming to levamisole, it is an ant-helminthic drug. It stimulates T cell functions primarily, but also affect B cells, monocyte and macrophage. In colorectal cancer, they can be used when combined with 5-fluorouracil, and there are also reports of help in slow spreading vitiligo. Thalidomide, we all know that it was introduced in the 1960s for the treatment of morning sickness, but later on, due to teratogenicity, the drug was withdrawn. Now, the drug was reintroduced to treat erythema nodosum leprosum and multiple myeloma because of its immunomodulatory and anti-inflammatory effect. They are also found to be helpful in refractory rheumatoid arthritis and certain malignancy, to be avoided in pregnancy. Coming to lenalidomide, basically it is a thalidomide analog having both immunomodulatory and anti-angiogenic properties like that of thalidomide. Now, it is useful for the treatment of transfusion-dependent anemia due to myelodysplastic syndrome. Adverse effect: neutropenia, thrombocytopenia, DVT and teratogenicity. Next topic, recombinant cytokines. Now, cytokines are gaining popularity as immunomodulators. They include aldesleukin, recombinant interleukin 1, ophrelvekin, that is recombinant interleukin 11, and colony stimulating factors. Aldesleukin is a recombinant IL-2 obtained from the cultures of E. coli, stimulate T helper and cytotoxic T cells. They are useful in the treatment of metastatic renal cell carcinoma and melanoma. Colony stimulating factors that include GM-CSF, that is sergramostim, GCSF filgrastim, and pegylated recombinant GCSF that include peg-filgrastim. Now, what does they cause? They cause differentiation, survival, proliferation, and differentiation of hematopoietic cells. GM, as the name suggests, granulocyte macrophage. So, sergramostim is virtually a multipotent hematopoietic growth factor that is linked with proliferation and differentiation of granulocytes, erythroids, megakaryocytes, and macrophages. Filgrastim, they are responsible for proliferation and differentiation of granulocytes, that is neutrophil progenitor cells. They activate the phagocytic activity of neutrophil and link with their survival. Peg-filgrastim basically is a pegylated GCSF, is a longer acting analog of filgrastim. Now, all of them, they reduce the severity and duration of the neutropenia induced by the cytotoxic therapy. Recombinant interferons that include interferon alpha and interferon alpha 2b. They are useful in treatment of cancers like chronic myeloid leukemia, hairy cell leukemia, non-Hodgkin's lymphoma, malignant melanoma, and AIDS-related Kaposi sarcoma. They are also useful in the treatment of hepatitis B virus, hepatitis C virus. Interferon beta 1a and beta 1b, it is used for the treatment of relapsing type of multiple sclerosis. Interferon gamma, particularly interferon gamma 1b, they are useful in the chronic granulomatous disease. That's all.